We are live.
Thank you. So welcome everyone to the All India Ophthalmic Society International Masterclass for today. This month's theme is on pediatric ophthalmology, and we have a world-renowned pediatric ophthalmologist and strabismologist, Dr. Burton Kushner. This session will run for about 2.5 hours. I'll now hand over to Dr. Pradeep Sharma, who is our chairperson, to introduce Dr. Kushner to all of us today.
Thank you, Manju. I think we are really privileged today to have amongst us Professor Kushner, a living legend in the field of strabismus and pediatric ophthalmology. It's been a great fortune of us that we can have him here. I would at the outset like to thank the officials of Aios who have started this international masterclass program in which we are featuring different super specialties of ophthalmology every month. And today we have pediatric ophthalmology and strabismus. Dr. Bert Kushner is a professor emeritus in the Department of Ophthalmology at the University of Wisconsin in Madison. He has been the program secretary of APOS, editor-in-chief, and also probably the founding editor of APOS and co-editor-in-chief of Binocular Vision and Ocular Motility. He has authored over 200 peer-reviewed manuscripts, 43 textbook chapters, edited 3 textbooks, and was the sole author of another 2 textbooks. Dr. Kushner has given 30 named lectures and received many awards, including the Heed Award, the Bressler Prize, and the Senior Honor Award from the AAO and the American Association of Pediatric Ophthalmology and Strabismus. He was listed in every annual edition of the Best Physicians in America and was listed as one of the 20 most innovative pediatric surgeons alive by top masters in healthcare administration. His passion has been understanding the mechanism behind and treatment of complex strabismus and the training of residents and fellows. Dr. Kushner has played a major role in training over 35 APOS fellows as well as multiple other international fellows. A quote from one of his former fellows: he's extremely humble, makes himself available for questions, truly cares about the education of the fellows, and has many pearls of wisdom to share. And that is what we are looking forward today here. It's just by chance that last month I was sitting across the table with Dr. Bert Kushner sipping coffee when I was invited to be doing the grand round at University of Wisconsin. And it's another day today that we are sitting across the globe and we are going to have the pearls of wisdom in the field of strabismus. So over to Bert Kushner for this great grand international masterclass.
Thank you, Dr. Sharma. So in addition, we have Dr. Pradeep Sharma, who really needs no introduction. He is the strabismus hero of India and widely known internationally. He's the chairperson for today's session. In addition, we have an expert panel and Dr. Samar Basar, who's the president of All India Ophthalmic Society. In addition, we have an expert panel from all over the country, pretty much north, south, east, and west. So Dr. Jai Kerkar, Dr. Pramod Pandey, Dr. Satya Ravali, Dr. Savleen Kaur, Dr. Soumya, Dr. Subhash Dadia, Dr. Sujata Guha, Dr. Suma Ganesh, Dr. Swati Fuljale, and Dr. B. Venkateshwar Rao. So our expert panels are also here to interact with Dr. Kushner and give their inputs for any question and answers. I'm Dr. Manju Bhate from LV Prasad Eye Institute. I'll be moderating along with Dr. Santosh Honavar and Manoj Mathur. And we have our young case presenters, again from different parts of the country, who will be presenting short cases for which we'll have some interaction with Dr. Kushner, Dr. Pradeep Sharma, and all the panelists. So with this, I'd invite Dr. Kushner to, so these are the range of cases that we have for today, and I think all of them are really going to be interesting. So with this, we'll move ahead and get started with the program. And I'd like to invite Dr. Kushner for his lecture on resurgeries and strabismus, your strategies, sir.
Thank you. Thank you, Dr. Sharma, for that lovely introduction. I trust you can see my slides now. Did they come up okay?
Oh, yes, sir. Carry on.
So first, I'll just say I took the liberty of a slight change in the title. In the States, we call it reoperations rather than resurgery. And I knew that if I typed in resurgery, I would continue to misspeak because I'm used to calling them reoperations. Same topic. And I also want to express my profound gratitude to the AIOS for giving me the honor of giving this lecture. Reoperations, I like this aphorism at the bottom. Uh, View every failure as a substantial step in a mission of trial and error. And that's the mental way that I approach the subject of reoperations. And in talking about reoperations today, I'm going to talk about three different aspects. One is far advanced planning, the actual making of a surgical plan, and then a little bit about intraoperative issues. So the first thing, advanced planning, I feel it's very helpful to get prior records if someone has had surgery before. And I've had colleagues say, I never need that. I can explore at surgery and see whatever I need. But there are a number of situations where it's particularly helpful. For example, if a patient previously had a posterior fixation suture, you would want to know that because normally in our surgical exploration, we're not going far enough back to see where a posterior fixation suture might have been placed. And if there is one there, if you recess or resect the tissue anterior to that and you don't know there's a posterior fixation, you're not going to get any effect from your surgery. Was an inferior oblique myectomy performed as opposed to perhaps a recession? Because if you're planning an inferior oblique anterior transposition, you may not be able to do that if there was a myectomy. Most importantly, you want to know if you're facing an overcorrection or an undercorrection. In other words, this exotrope you're looking at, were they initially esotropic or were they exotropic and just undercorrected? Because this will greatly influence your decision, which we will talk about later in this lecture, as to whether to operate previously unoperated muscles or operate fresh muscles. And you want to know if vertical surgery was done, if a lateral rectus resection had been performed, or if a sclerobuckle had been placed, because you may be dealing with an oblique muscle incarceration, which you wouldn't be expecting if you didn't know this had been done. And finally, if a large recession had been done on a hangback, you very likely may be dealing with non-adherence if that is an underacting muscle. Now, there was a doctor in Michigan in the late 1940s named Cooper, who is often quoted, actually misquoted, with something that is referred to as Cooper's dictum. Whenever I'm on a panel and we're discussing reoperation, someone always mumbles under their breath, Cooper's dictum. And they claim that Cooper said that when you're doing a reoperation, approach it as a fresh case. In other words, it doesn't matter what was done before. Just look at what you have and treat it as though there was no prior surgery. Now, in other words, he's saying don't make allowances for what was previously done. And there are many exceptions to that. In fact, Cooper is really being quoted out of context because when he said whatever he said, it was in the narrow context of dealing with a routine consecutive exotrope. And back in the 1940s and 50s, in the United States at least, a common precept was that you should always advance the medial rectus muscles with a consecutive exotropia and perhaps do more surgery than was previously done, as opposed to operating on the lateral rectus muscles. This is what Cooper actually wrote, in fact, and he's not cited that way. Whenever an overcorrection results from extraocular muscle surgery, the case should be reevaluated based on the diagnostic findings after the last operation. It is inadvisable to assume one should undergo prior surgery. The idea that surgery for consecutive exotropia should always undo what was previously done should be rejected. So I would say Cooper's dictum, or at least the way he is misquoted, should be amended. There are many exceptions. If you're dealing with a restriction, if you're dealing with a lost or slipped or just a weak muscle, perhaps a stretched scar, you don't want to follow it. If there are distance near differences, any concomitants, and certainly if there's a new diagnosis after the prior surgery of Graves' disease, trauma, myasthenia, or even refraction changes, you probably should not follow what is described as Cooper's dictum. So, bearing that in mind, we're going to go into a decision tree of how you approach reoperation. And the first decision is, should you operate fresh muscles or previously operated muscles? In other words, esotropia, medial rectus recessions, now you need to do more surgery. Do you go back on the medials or do you operate the laterals? And I like to follow this schema, and we're going to kind of talk about this each leg of the tree down the line. So we're starting with the question, fresh or previously operated muscles. And the first thing you have to answer then is there a limitation of rotation or no limitation of rotation? Because that's going to influence the decision. Let's go down the left side here. Let's assume there is a limitation of rotation. You have to go back to the previously operated muscles in this case. Well, you've done medials for an ET, there's an exo, there's an underacting medial, the eye doesn't adduct well, you've got to go back and look at that medial rectus muscle. Here's a patient who had previous medial rectus recessions. You can see she has in the lower right a left exotropia and a marked limitation of adduction. You must explore the left medial rectus in this case. Here's another child, similar history. She had medial rectus recessions and she has a left exotropia, which we can see here, and almost no adduction. This is an MRI, a dynamic MRI, and it shows the very typical appearance of a muscle slipped in the capsule or a stretched scar. We're going to talk about those two entities close to the end of this lecture. So in the right-hand scan, she's looking to her left, abducting, abducting the left eye, and it looks fairly normal. But on attempted adduction in this left-hand scan, you see this very typical fusiform dilatation of the muscle posteriorly and this thin band of tissue attaching it to the globe. And this is very typical for either a muscle slipped in the capsule or a stretch scar. They're different entities. They look the same on imaging. But I want to introduce something that may be new to you. It's something that my radiologist has coined the term the collapsed empty channel sign. This is a scan that looks very similar to the one we just saw. But the difference is this is the eye in primary gaze. It's not an attempted adduction. In the previous one, when the eye was not in adduction, the medial rectus looked normal. So these are cases, this patient clinically looked like a lost muscle. And you look at the scan and say, oh, it's attached to the globe. I can easily go back and find that muscle. And when you go in at surgery, you find there's no attachment to the globe at all. What happens, we think, is that the muscle is lost. It retracts in the orbit. The opposing layers of orbital fat come together and create an interface which shows up on imaging and looks very much like a band of muscle or tendon attaching to the globe. So it's the channel the muscle was in that is collapsed and empty. And this is something to be wary of because in this case, there is no attachment of the muscle to the globe. So back to our decision tree. We talked about limitation of rotation. Now on the right, we have no limitation of rotation. And here you need to determine whether you're dealing with an overcorrection or an undercorrection. In other words, is this exotrope that I'm looking at a prior esotrope that's overcorrected, or is it an exotrope that had surgery and went exotropic again? And this is one reason why prior records are helpful. Even if you can't get full records of the prior surgery, very often the patient or the patient's parents will at least remember that before the surgery, the eye was crossed, esotropic or exotropic or whatever. So if you can, and this is our next step, and we're going to talk about these two options separately. So no limitation, is it an overcorrection or undercorrection? If it's an overcorrection, my decision tree is based on, is there any incompetence in the form of a convergence insufficiency or a divergence insufficiency pattern? In other words, I have an esotrope, they had surgery, they're exotropic, but now they have a convergence insufficiency pattern. They're more exotropic at near, or conversely, a divergence insufficiency for a consecutive esotrope. These are soft signs, a pattern like that, for an underacting muscle. And I think you need to go back on the previously operated muscles. On the other hand, if you're dealing with an overcorrection and no limitation of rotation, and there's no convergence insufficiency or divergence insufficiency pattern, I would go back and operate on the fresh muscles. In other words, I did the medials, the patient's exotropic. I would just go back and operate on the lateral rectus muscles as I would for any exotrope. Soft sign for muscle underaction. Now, if we're dealing with an undercorrection, so a patient is exotropic and they previously had been exotropic, what I decide then is, was the prior surgery close to what I'd consider a maximum amount? Let's say they're exotropic now, they were exotropic before, and the records show their prior surgery was only 4 or 5 millimeters on the lateral. I will operate fresh muscles. I'm sorry, I went down the wrong side. If it was close to maximum, so they had exotropic, let's say 7 or 8 millimeters on the laterals, I will operate fresh muscles. I'll resect or placate the medial rectus muscles and maybe just scale back my formula a little bit if the prior recessions were large. On the other hand, and this is what I inappropriately started to say, if it's an undercorrection and the prior surgery was modest, again, exotropia, only 4 or 5 millimeters on the lateral, and if there's no incompetence, I would re-recess the lateral rectus muscles. There's a caveat, and I want to talk about this, and that's the situation of lateral incompetence, an undercorrected exotrope with lateral incompetence. Lateral incompetence meaning the deviation decreases in both right and left gaze. Let's say you're 30 exo in primary, 15 in both right and left gaze. And I want to talk about this. I haven't seen this, what I'm about to say, in the literature anywhere, although it is in some textbooks. And I want to digress for a minute from the concept of reoperations. And I want to talk about a de novo, meaning no prior surgery, entity called exotropia with lateral incompetence. It was described by an orthoptist, Sally Moore, in 1969. And she observed that patients, no prior surgery, exotropia that decreases in right and left gaze, 30 in primary, 15 in right, left gaze, are very prone to overcorrection with standard surgery. And I want to look at this for a minute. What mechanically can cause a pattern like this? Well, it could be due to tight, or I'll say overacting medials, 30 exo in primary. On side gaze, the adducting eye adducts more than normal because the medial is overacting. That could cause a pattern like this. Or it could be caused by weak laterals, 30 exo, when they look to the side, the abducting eye doesn't move as far, and you have less of an exo. Well, which of these causes this entity? I personally have a very hard time accepting the fact that a patient that is de novo exotropic has weak lateral rectus muscles. So I think this has to be due to overacting medial rectus muscles. And it stands to reason that if the medials are overacting and you do standard surgery, Those overacting medials are going to overpower your weakened laterals, and you get an overcorrection. So that's what I just said. Medials should be prone to overcorrection if they're overacting. Now, when you get the same pattern after lateral rectus recessions, it's different. Now, laterals recess, you're dealing with iatrogenically weakened lateral rectus muscles. They should not be prone to overcorrection in primary position. But because of the horizontal incompetence, they may be prone to overcorrection in side gaze, and you need to tailor your surgery accordingly. So I'm often seeing a patient, they had surgery before, lateral recession, and the person consulting with me will say, well, there's a lateral incompetence pattern. What do I do? You don't have to worry about it the same way as you do with a de novo exo with lateral incompetence. Surgical doses after prior surgery on a muscle. I think formulas are very questionable. They don't apply to a muscle that's been previously operated. This is one reason I'm very fond of adjustable sutures in reoperation situations. A couple of sort of key points. Prior recessed muscles shorten and they become stiff. So an advancement or plication will have a bigger effect than normal. So take that into account. If there's a prior recession, you want to respect the arc of contact if you're going to re-recess. So medial's been recessed, let's say 5 millimeters, and for whatever reason you want to re-recess it, a small re-recession can have a very big effect and in fact cripple the muscle because you're losing your arc of contact. So again, formulas may not apply. And finally, prior resections, especially if done years ago, may have loosened. The muscle undergoes sarcomere remodeling and it stretches out, and you can go back and re-resect the muscle the full amount you might normally do, even if it had a big recession years ago. You have to make that judgment at surgery. Now, I'm often asked, in recent years, at least in the States, plications have become very popular and are perhaps supplanting resections and advancements. I'm asked, is a millimeter of advancement of a recessed muscle equal to a millimeter of resection or plication? And I would say, as far as the length tension curve of the muscle, the sarcomere length, it's exactly the same. A millimeter advancement is exactly the same as a millimeter of resection or plication, but only with respect to the length tension curve. It doesn't increase the arc of contact. Resection or plication does not increase the arc of contact the way an advancement does. So for that reason, I'd say advancements are a little bit more powerful, millimeter for millimeter. I think whenever you go in on a reoperation, you have to be prepared to alter your surgical plan. I like to say expect the unexpected. Muscles may not be where they were, where you expect them to be, and you may find evidence of prior surgery that you didn't even know had occurred. I like this aphorism. A 20th century comedian said, if you want to make God laugh, tell him your plan. And I think that's absolutely appropriate when dealing with a reoperation. Of course, you want to go into it with a plan in mind, but you've got to be quick on your feet and have backup plans and be prepared to alter depending on what you find. A little bit about timing when you do a reoperation. Now, I'm talking about in the early post-op period if you don't get what you want. Obviously, a patient comes years after surgery. You operate whenever it's convenient. In general, I like to wait at least 6 or 8 weeks. Weeks 2 and 3 after surgery there's the most edema, the most bleeding. It's just messy and it's more difficult. So if I know the patient's going to need reoperation, I'll wait 6 or 8 weeks when things quiet down, with a few exceptions. If I know from the start I'm dealing with a slipped or lost muscle, if I see a big overcorrection, after a superior oblique tuck. A small overcorrection is often okay because the tuck tendon stretches out. If I have more than 5 of hyper after a vertical rectus transposition, I'll go back on day 1 or 2 if I can. And if I can't fit it in, the patient didn't come in, I'll then, even in this case, these cases, wait 6 or 8 weeks. Okay, a little bit about technique with reoperations. There are things that are different. Advanced planning, again, if it's a very heavily vascularly scarred eye, I'll sometimes use topical steroids, maybe 4 times a day for a couple of weeks, possibly vasoconstrictors, and I'm going to be more liberal in my use of postoperative steroids. I almost never use systemic steroids postoperatively, but topical steroids would be definitely part of the management. Under anesthesia, number 1, you want to pay attention to forced ductions. And I want to call your attention to what's called a reverse leash restriction. So this is a picture of an eye. This is the nasal orbital bone. So this is nasal, this is temporal. And forced ductions are positive to adduction. Now, usually, if you can't passively rotate an eye into adduction, the restrictions out here laterally. But if you don't find a restriction laterally, consider the possibility of a reverse leash. And that's depicted here by this artist drawing. You have a band of scar tissue coming from the anterior orbital wall, running posteriorly to attaching to the globe. My cursor disappeared. So you can see that that would restrict the eye from adducting. So here, positive for adduction, restriction is nasal. One thing about reverse leash restrictions is they increase with retropulsion, and that can be which you could easily imagine by looking at this picture. So that could be a tip-off. I like to do rotary force ductions. I just grab the eye at either 6 and 12 o'clock or 3 and 9 o'clock, and I rotate it clockwise and counterclockwise. And I want to look for symmetry. You can see in the top picture, I can rotate the eye clockwise further than counterclockwise. And that's a torsional restriction. And looking for that will help, knowing it's there will help guide you with your surgery. That's different than the exaggerated force duction for the oblique muscles, which was originally described by Dave Guyton. And I'm going to show you a video of it. This is the video Dave Guyton actually used when he first presented this concept at the APOS meeting, and he generously let me use this video. I'm going to play this.
We're going to be seeing the left eye of a patient seen from above. Horizontal force ductions in the usual manner are normal. To test for torsional restriction, it helps to retropulse the globe, which puts the oblique muscles on stretch. Rotary force ductions can be done in this manner to look for a torsional restriction. Look for symmetry. To test for oblique muscle tightness, grab the eye at 3 and 9 o'clock. For the superior oblique, push the nasal force up into the superior nasal quadrant and rock the eye temporally in this manner. You can see and feel the eye roll over the superior oblique tendon. For the inferior oblique, do the same in the inferior nasal quadrant. This amount of tightness is normal. We are now going to see a patient with superior oblique overaction and a pattern. When testing for the superior oblique, you can see this marked 3+ restriction as the eye rolls over the tight superior oblique. The inferior oblique is normal. Look at the eye just snap over the superior oblique. Bilateral superior oblique tenotomies were performed and the maneuver repeated. The eye now moves freely when testing for the superior oblique, indicating that the tenotomy was complete.
So subsequent to the original description, and I think Dave Guyton also have modified from what you've seen just using one forcep in either the superior or an inferior nasal quadrant. It's a little gentler on the eye, and it gives you the same information. The spring back test was described by Art Jampolsky, and I use this in surgery. So in the top, you see you rotate the eye back and forth under anesthesia, and then you pull it into, let's say, in the lower of the part of the drawing, the nose is over here on the left side, so we're pushing the eye into abduction, pull the far into abduction, let go, and see the eye spring back. It usually won't go to primary, but you note where it springs back to. Then you do the same, releasing the eye from adduction and see where it springs back to. And you kind of average those two positions, and it should be around the straight ahead primary position. And if not, you've got a mechanical restriction bias for either adduction or abduction. It's a very useful test. However, this shows they're looking for symmetry on the bottom. But important to note, it doesn't give you your final endpoint of surgery. In other words, the endpoint of surgery isn't, oh, now I've got symmetry with my spring back test, because this doesn't assess innervational factors. For example, let's take a hypothetical hyperbole of an example, but let's say a patient, motor vehicle accident, lateral rectus paralysis, big esotropia, and if for some reason I had that patient in the operating room on day one, you wouldn't, but if you did, and if you did a spring back test, it would be normal because no secondary changes in the form of contracture of muscles would have occurred. Yet clearly the patient has a big esotropia. You wouldn't be done. You'd have to straighten the eye. So all this tells is whether you have balanced the mechanical restrictive forces. Look for what Art Jampolsky called a string sign. Rotate the eye, in this case, in extreme gaze, and look for this line, almost like a string indenting the conjunctiva. That's a sign of a conjunctival restriction, and you may need to either remove scar tissue or recess conjunctiva, but you're dealing with restriction at the conjunctival level. I like to do force ductions as you go, the spring back balance test as you go, and I'll sometimes use temporary bow knots, position a muscle, tie it with a temporary knot, do my force duction spring back test, and then if I'm not happy with the position of the eye or the way it behaves, I can undo the bow knot and further recess or advance the muscle. You want to avoid anterior segment ischemia because often on reops, you're operating other muscles. You may or may not know what was done before. And of course, we know if you detach all four muscles too close together, all four rectus muscles too close together, you can get anterior segment ischemia. Several things you can do to prevent that. One is vessel sparing. Craig McEwen described this, where you very tediously dissect the vessel off the muscle, as shown in the left-hand picture, and then you can take the muscle underneath those vessels and recess it, or plicate it, or advance it, resect it rather, without damaging vessels at all. If you're doing a transposition and other muscles have been operated, you might do partial transpositions. This slide on your right shows that half the superior rectus and half the inferior rectus have been transposed, and the other half left intact to keep anterior ciliary vessels undisturbed. A more recently described and popular procedure for transpositions to avoid anterior segment ischemia is the Nishida procedure. And what you see on the left-hand side is you put sutures in the vertical rectus muscles, just in the belly of the muscle, a little distance back, and you don't attach the muscle at all. And then you put an arm of the suture in the sclera, and you pull it up. And as you see on the right-hand side, that will transpose or drag over the temporal half, if we're talking about doing it temporally, of the muscle. you'll get a good transposition effect, and you haven't attached any muscles. And I think this is rapidly becoming the procedure of choice for transpositions, but it is relatively new. You can augment with Botox. Let's say you've got a vertical and a horizontal deviation. You need to operate the two vertical rectus muscles. You could put Botox in the medial rectus muscle instead of recessing it. Botox at surgery. And I find that a useful way of avoiding doing a third or maybe fourth muscle in one sitting. A word about these orbital cysts that occur. They can be very tricky, and I'll share my experience with this. Often what you're seeing is the tip of the iceberg. This cyst looks moderately large, but it doesn't seem like it would be that difficult to remove. But at surgery, this is what we found. This part of the cyst on the left, this is all we were seeing, and all this was back in the orbit. So you want to prepare yourself for something bigger than it looks. But here's the important finding. Look at this structure here where my cursor is. That's the muscle attached to the cyst, not to the globe. What happens is the cyst forms, theoretically, when you put your sutures through the scleral tunnel. If you're dragging epithelial cells through the tunnel, that could give rise to cyst formation. The cyst forms between the muscle and its new attachment to the globe. And the muscle can stay attached to the cyst. So if you look on the right, this is an artist's drawing. The muscle is here. It's not attached to the globe at all. And to make matters more confusing, there's often a pseudotendon running from under the muscle to the insertion. If you don't know what to look for, you're going to think that that's the muscle. You excise the cyst, and you end up with a lost muscle. And I have seen, when I published this, I think I had seen 7 or 8 cases. I've easily seen another equal amount in my practice of lost muscles related to removal of one of these orbital cysts. And then Linda Doggy from Boston kindly gave me this scan of a patient of hers showing exactly what I conceptualized with the artist drawing. Here's the cyst, the globe, the muscle attaches to the back of the cyst, no attachment to the globe at all. So do be careful of those. When you hook a previously operated muscle, normally we just pass a hook under the muscle and it slides easily. The hook may not slide if the muscle's scarred down. And what I'll often do is just push that hook through, and the tip will come out the other side of the muscle with all sorts of connective tissue on it. And then I need to do a sharp dissection down on the hook to get it to pop through and get a clean, bare tip of the hook. Word about slip muscles and stretch scars. Clinically, they look the same. They're similar. They're markedly underacting muscles that have been previously operated. I think whether you're dealing with either a stretch scar or a slip muscle, you have to completely excise either the empty capsule on a slip muscle or the stretch scar so that you're suturing good, healthy muscle to the sclera. But I want to talk about the role of absorbable versus non-absorbable sutures. And here are the differences between a slip muscle and a stretch scar. A slip muscle is due to inadequate suturing. In theory, when you pass the suture through the muscle, if you just pass it through capsule and not muscle itself and attach that to the new insertion point, the muscle in the capsule will slip back. So they occur sooner than a stretch scar. The tissue you will see when you're looking at it is thinner, it's empty capsule, and it's usually unilateral because it's surgeon error. There's no reason, unless the surgeon made the same suturing error on both sides, it'll just occur on one side. So it shouldn't recur if you don't make the same error, and you can use absorbable sutures. Whereas a stretch scar, according to Irene Ludwig, who is the person who described this, is due to an intrinsic healing problem on the patient's part. So it occurs later. It involves remodeling of scar tissue. The tissue's thicker at surgery. It's often bilateral because if it's a healing problem, if it occurs in one eye, it occurs in the other, and it'll often recur for the same reason it occurred the first time. And in that case, I will use absorbable sutures, as Dr. Ludwig advises. This picture on your left is a muscle slipped in the capsule, and this arrow points to the interface where the actual muscle begins, and this is all thin, empty capsule anterior to it. The stretch scar is on your right, and the interface between muscle and scar can be harder to detect. Here you see a little ridge. I'll pass a hook back and forth, and I'll feel a bump when I get to the healthy muscle. And you have to excise that. This is the girl that I showed you earlier and showed you her MRI, which showed what I said was slipped muscle in the capsule or stretch scar. She had a stretch scar. I excised 14 millimeters of scar. It was all connective tissue. There was no muscle fiber in it. And here she is immediately post-op, and she had a good result. Now, what I've just described is separate and not at all related to a pseudotendon, which very commonly occurs after a recession. This is a histopath section of a globe. Muscle is recessed. Here's the recessed muscle. And a pseudotendon, when you do a recession, often grows from the front of the muscle. Usually it goes all the way to the old insertion. In this particular slide, it stops here. And it's very easy at surgery to think this is muscle. If you pass a hook and it looks like the muscle's more anterior than you expected, think you have a pseudotendon. Pass that hook further back, and then you'll grab the actual tendon. This is completely different than the stretch scar and slip muscle. In this case, the muscle's attaching right where it was put. There's just stuff in front of it. And that tissue is of no use. You can excise it and just get rid of it. Whenever you've had either prior superior rectus surgery, superior oblique surgery, or scleral buckle, consider a restrictive, and you have a restrictive hypertropia with an encyclo, think of superior oblique incarceration. This is a patient that had a previous superior rectus resection that dragged the superior oblique forward. And here you see between the black dots, the superior rectus, and this is the superior oblique, scarred into the insertion of the superior rectus. And that causes a restrictive hyper with an encyclo. You can get that with the inferior oblique, and I've seen this after lateral rectus resections, which can pull the inferior oblique forward, or after a scleral buckle. This is an artist drawing of a scleral buckle where when they hooked the inferior rectus to place the silicone band under it, they hooked the inferior oblique, and the inferior oblique is basically tucked by the encircling band. And that will cause a restrictive hypotropia with an excyclo. If patients had a scleral buckle, in my experience, and this is controversial, but my experience is I rarely need to remove the buckle. One thing you can do is you can just ignore the muscle that's on top of the buckle and start your surgery posterior to it, and just suture there and recess or resect or whatever you're going to do. If you're going to use adjustable sutures, people often wonder, do they need absorbable or non-absorbable sutures? I find that absorbable sutures are okay if the buckle isn't laid bare, if it's still in its fibrous capsule. The muscle will adhere to that fibrous capsule. But if in the course of your surgery to do your dissection, you end up looking at raw, bare silicone, muscle will not adhere to that. And you should use non-absorbable sutures. So in a brief summary, we've talked about decision one. Do you operate fresh muscles or previously operated? Is there a limitation of rotation? Are you dealing with an overcorrection or undercorrection? And from there, your decision tree goes. A little bit about timing, a little bit about technical issues. So I would say when dealing with a reoperation, you should follow Cooper's dictum, except when you shouldn't. A lot of reasons when you shouldn't. And I want to digress, if I can take the liberty to share something with you. This is not directly part of my talk, but there's a very exciting new opportunity that some of you may be interested in, and I was involved with this. And the One World, One Vision is a philanthropic organization that has recruited me to put together a comprehensive course on strabismus that is free online, anybody worldwide. It's 17 lectures, has some of the leading experts in the world giving lectures. It went live about a couple months ago, and I think we've had close to 10,000 hits. So, and it's free. I have no commercial interest in this, but the feedback we've gotten is tremendous. In the States, a number of residency programs are incorporating this as part of their standard residency training. It's available at oneworldonevision.org/videos. Scan the QR code, but I just realized on this Zoom, on my view of the QR code is covered up. Let me see if I can open it up there. And that'll get you right to it. And that's something you're all welcome to avail yourself of. So with that, let me get this off. I want to thank you. And again, my profound thanks to the Aios for the honor of letting me speak before you today. Thank you. And I will end my screen share.
Right. Thank you so much, Dr. Kushner. That was wonderful. We were just glued to your lecture and listening to you and your pearls on strabismus resurgery. So I think we could take a few, if you're happy, we could have a few questions and then proceed to the second part, that is the case presentation. So maybe about 10 minutes or so. So I'd like to start with Dr. Pradeep Sharma. And then the panelists, if there are any in the chat box. So over to you, Dr. Pradeep Sharma, for
I
any
think it was
questions,
really a
comments.
wonderful lecture. In that short time, he has covered so much, and it's really a garland of pearls that we have been listening to. It's wonderful that he has presented the important points like the lateral incomitance, the sarcomere remodeling, the arc of contact, the importance which many a time people may not realize when they are dealing with the resurgeries. And his plan, that algorithm which he has shown, is really something which we should follow. It's good that this lecture is going to be available even later on, because there are so many pearls which we may not have been able to digest in this short period. We can always look back and see those things. And there is a wonderful book by Dr. Kushner, the pearls, which are also there in that book. So those residents and fellows, I would really recommend that they should go. I keep on looking into that book and really enjoy that book too. So if there are any questions from people, I think let's go on.
Sure, let's do that. So maybe I'd just like to start with one quick question. Dr. Kushner, do you often recess the conjunctiva in resurgeries, or do you kind of keep it individualized, or do you think sometimes it could cause a bit of a tight compartment? How do you go about addressing the conjunctiva?
So I don't have a set one size fits all. I don't either say I always recess it or I don't recess it. I make a judgment based on whether it's tight, whether it's causing a restriction. And one thing I might do, probably do this. So my my routine, I'm digressing for a minute. My routine for reoperations is to use a limbal incision to approach the muscle. In most cases, I'll rarely use the fornix incision on a reoperation. Actually, there are some cases, not many, but there are some where I'll use a modification of the old swan incision, which is cutting down over the muscle. And that actually has a very bad reputation because of the scar formation. But if you make the incision, if it's medial, right in front of the semilunar fold,
Yeah.
and if it's lateral, if you pull the eye into adduction and put it way lateral, so it's buried under the lateral orbital bone when the eye is straight, the
Yes.
scar is fine. I might do that if there's very extensive scarring in front of from the limbus back, but not that often. So I'll use a limbal approach for most cases, and then I'll see at the end, I'm done with my recess, whatever I do, and I'll pull the conjunctiva up and see if it's tight. And if I think it's not, I'll close, and then I'll close anatomically, repeat forced suctions. And if I think I've increased restriction, I'll recess it. The other thing is that sometimes recessing it is part of management of an unaesthetic nasal scar. Sometimes it'll just look better if I push the conjunctiva way back and let bare sclera epithelialize in. But in general, if I feel I'm not sacrificing motility by closing anatomically, I prefer that because I'm always thinking about what if someone has to go back later?
Yeah.
And if I've recessed conjunctiva, um, that precludes they may not be able to advance a muscle because then it would be anterior. Once it's recessed, you're not going to be able to pull it forward on a subsequent operation because it shortens. So, that's how I would address that.
It's great. Thank you so much. Thanks for that. So is there any other I think there's something in the chat box. So no, not really.
Dr. Manju,
Yes.
one comment is there, not a question. Basically, these recent modalities like ASOCT, they are very useful in reoperations, whether you want to operate on the fresh muscle or in the previously operated muscle. So that part was,
Sure.
and that part.
I think we have a case as well, so maybe that could be a bit of a discussion with that case. Yeah, that's.
I had a question, Dr. Kushner. There has been a few instances when during reoperations, the conjunctiva has been completely torn. It was so adherent. Have you had any instance where you have had to do some amniotic membrane transplant or something for the conjunctival closure?
I'm aware of cases like that. I personally have not used amniotic membrane for conjunctiva. Some of my colleagues do. I just don't have experience with it. I've found I think I just haven't needed it. I know how to do it. I'm aware of it. There are some cases so if the conjunctiva is really heavily scarred between the limbus and back to the muscle, that might be a case where I would make my incision anterior to the muscle, over the muscle, like I described. Now, an exception would be if it's not just scarred down, but I think I need to improve the appearance of it, heavily vascularized, scarred, in which case I would do the best I can to dissect it free and recess it back. But I just haven't found the need for the amniotic membrane. Maybe I'm missing something by not doing that. I don't know.
We probably haven't handled it as nicely as you.
Right. If there's any other question, or we could move on to the cases and have discussions in between. So
Yeah.
I think the Delhi people are going to go in first. So it's Vaishali Tomar. If you are ready with your case, would you like to share your slides?
Yes, ma'am.
And after Vaishali, we'll go straight with Arushi. And after these two cases, we'll have a bit of discussion. So Arushi, if you can also be ready as well.
Yeah.
Thanks.
Yes, ma'am.
Are you able to share your slides? Vaishali?
I think we are not getting any communication from her.
No, I can't hear.
Yeah. I think you can ask Arushi to start
Arushi, yes.
if she's ready. Yeah, the next. Then we can have Vaishali after that.
Yeah, sure. Arushi, would you like to share your slides, please?
Yes, ma'am. I'll start sharing.
Thanks.
Are my slides visible?
Yes.
Yes, please go ahead.
Thank you everyone for giving me this opportunity to present this case titled The Oblique Tackle. I have no financial disclosures. A 30-year-old female presented to our OPD with chief complaints of outward deviation of the right eye, as can be seen in the clinical picture. She gave history of strabismus surgeries elsewhere. On imploring further, we found out that she had the first surgery at the age of 1 year in 1994, where she underwent both eye MR recession of 3.5 mm. She had esotropia at that time. The second surgery took place at the age of 30 years in January 2023, where she underwent both eye inferior oblique anterization and right eye MR re-recession of 3 mm. On ocular examination, the best corrected visual acuity in both the eyes was 6/6, near vision was N6, and intraocular pressure was normal. The refraction was -3 diopter cylinder in both eyes. In the anterior segment, there was both eye nasal conjunctival scarring, and rest of the anterior segment examination was normal, and posterior segment was also within normal limits. The head posture was erect, the facial symmetry was present on both the sides. However, on extraocular movements, there was a right eye adduction limitation of -2 and both eye superior oblique overaction of +3. The fixation was central, steady and maintained in both the eyes. And on prism bar cover test, there was a consecutive exotropia of 20 prism diopters basin with A pattern. The findings of the prism bar cover test are as follows. In the up gaze, it was 14 PD. In the primary gaze, it was 20 PD, and down gaze, it was 45 PD. There was a significant difference between up gaze and down gaze, confirming the A pattern. This is a 9-gaze clinical photograph of the patient preoperatively, in which you can see that there is a significant A pattern along with both eye superior oblique overaction. The timeline of the patient is as follows. She underwent both eye MR recession for esotropia in a young age. Then she underwent right eye MR re-recession with both eye inferior oblique anterization. And then she presented to us with consecutive exotropia with A pattern. So the final diagnosis was right eye consecutive exotropia with V pattern, right eye adduction limitation, and both eye superior oblique overaction. The
A
management.
pattern. A pattern.
Yes, sir.
How do you want me to comment? How does this work?
So should I continue?
Yeah, if you
Oh, okay.
finish your, maybe we can.
The management plan included a force duction test, just a second, a force duction test which was found to be free for both the LRs, exploration of the right eye MR followed by advancement of 4.5 mm, and both eye posterior tenectomy of the superior oblique. This is the clinical photograph taken post-operatively 5 hours after surgery, in which you can see there is orthophoria in the primary gaze, the A pattern has resolved, and the both eye superior oblique overaction has also been taken care of. Post-op 1 month, the patient was happy with orthophoria in the primary gaze and no A pattern. Discussion and highlights of this case. There was a significant A pattern after previous inferior oblique anterization, which we do not know why it was done, but we presume that it was an incorrectly diagnosed DVD. There was resolution of A pattern with PTSO in the third surgery. A re-recession of the MR was done in the second surgery, which led to adduction limitation, and this was taken care of by re-advancing the MR, and hence restoration of full motility was achieved. Orthophoria in primary gaze as consecutive exotropia also got corrected, and the patient was happy. Challenges in management in our case included most commonly preoperatively. Records of previous surgeries were difficult to obtain. Assessment of pattern deviation and ocular rotation was of utmost importance in this case. Careful planning and counseling the patient for realistic expectation was also important. Intraoperatively, since the patient had been operated twice, there was scarring and bleeding. And post-operatively, managing expectations or any over and under correction was important, but the patient was happy in this case. Concluding, proper history and record maintenance help in management of such cases. MR exploration and re-advancement was useful in our case to correct the consecutive exotropia. Missed pattern deviations and missed cyclovertical muscle dysfunctions can lead to unsatisfactory outcomes, and inferior oblique weakening procedures should be planned cautiously. Thank you.
Yeah, now we can have Dr. Kushner's comments. Yeah.
Yeah, just before I comment, just a question. When you went back and advanced the medial rectus muscle in the right eye, do you know how far back you found it?
So it was present approximately 7 mm behind the limbus. Sorry, 7 mm behind the insertion point.
Behind the insertion.
Yes.
Yeah. Well, just a couple of comments. Of course, it's always easier to criticize someone else's prior surgery, but a re-recession of the medial rectus that far is problematic, and it lends itself to a fairly predictable undercorrection. It's interesting, and I think some of this has to do with the growth of the eye. There are people who will not routinely, but for very large infantile esotropes in children, put a muscle recess a medial rectus 7 millimeters, and they do okay. You can't do that in an eye that's more fully developed. I recall one patient, and this is very interesting to me. As an aside, and it's relevant, she happened to have been the index case of the anti-elevation syndrome. She's the patient that I first diagnosed that on a colleague who did her inferior oblique surgery recessed her medials. It was 7 or a little more, maybe 7.5. It was at least 7 millimeters. And I met this girl when she was about 6 or 7 years old. She had already had her medials recessed 7, and she had, full adduction. And then somewhere between when I met her and about age 16 or 17, she went exotropic and developed an underacting medial. And I found her medial rectus 15 millimeters from the limbus. And I'm thinking, unless it moved from age 6 or 7 to that, she initially had full adduction with a muscle that far back. It was astonishing to me. Now, I don't know how the whole understanding of pulleys would come into that and what we do in a very young child and how the growth of the eye affects it. But I would say when I'm looking at a patient like this, I would say, and I think you got a great result, 2 things. The exo is either a function of the fact that she had too much of a re-recession, or she developed a stretch scar. That's why I asked where you found the muscle. If you found it that far back, I think that can explain it. The other thing is the pattern. Whenever someone's had inferior oblique anterior transposition, and it's a procedure that I utilize, but it really can wreak havoc with comitants. And I didn't think this patient had anti-elevation, but at least I've seen anti-elevation. It usually causes a big V pattern, and it usually causes a bigger limitation of elevation in a B duction, and this had a deduction. So I would assume, and you were correct in your approach to it, that this was superior oblique overaction, as opposed to something with the inferior oblique. But I would, if I'm operating that patient, I would want things to reassure me. I'd want to see what fundus torsion is. If this is an anti-elevation syndrome or anything related to the, rather than just an overcorrection from the inferior oblique surgery, she'd be ex-cyclotropic. And if it's true superior oblique overaction, as marked as it was, she'd be in-cyclotropic on fundoscopy. So I would have that factor in. I'd pay attention to the exaggerated oblique forceductions at surgery. If she had a tight superior oblique on the Guyton type of forceduction testing, I'd feel more comfortable that it was superior oblique. You're correct in approaching the superior oblique. The thing that surprises me is that you got that much effect with a posterior tenectomy of the superior oblique. I tend to, in my hands, I use it, but it's a fairly weak superior oblique weakening procedure. And when I see this much overaction, I'm more inclined to do a larger more powerful weakening procedure. I think if I recall the slides, I think there was some residual superior oblique overaction if you look at the versions in the right eye, I think. Yeah, she's turned her head a little. I think that the right is a little overacting there, maybe the left too, but she doesn't have a pattern. So, I think that's right. I mean, it's a very informative case and a good result. Thank you.
Thank you, Dr. Kushner. I think what you have rightly remarked that the primary problem was over recession, which created the other pitfall, which I would like to keep the people in mind is that if you are thinking of a DVD, which may be sometimes because of a overacting superior obliques, you may have in abduction hypertropia, which you feel that it's a DVD. And the second mistake, which the other surgeon probably made was doing IO inferior oblique weakening in the absence of inferior oblique overactions. So in DVDs, if there are no inferior oblique overactions, and if you do an inferior oblique weakening procedure, you are bound to cause more of superior oblique overactions like this case had. And there was the result of A pattern, which was very severe. And A patterns are much more disturbing because in the down gaze, the problem is much more appreciated by the patient. So this is what I think the take home would be, that you should be cautious while handling the inferior obliques. Even if it was a DVD, we should not be doing inferior oblique weakening unless there is an inferior oblique overactions.
I think we should evaluate torsion in all these cases. I think the mistake we make, we don't evaluate torsion and then we don't correlate with these inferior oblique or superior oblique overactions. Because just because there's elevation in adduction doesn't always mean that this is inferior oblique overaction. So I think that's an important step we often overlook and we don't take that into account and we get into all these issues, to my mind.
Quite right, Dr. Point. So I think, can you stop sharing, Arushi? So
Yes, sir. Yes, sir.
Thank you so much for a good presentation.
That was a great presentation. Thank you so much. And Vaishali, if you're ready, do you want to start sharing your slides, please?
Yes, ma'am.
And just after Vaishali, we will have Ashish. So Ashish, would you like to be ready as well? Ashish Sunkarpalli.
Yes, ma'am.
Charlie is having some problems, seems. Oh, it's there. Right.
Is my screen visible, ma'am?
Yes.
Yes. Can you go to slideshow mode?
Yes, ma'am. Good evening, everyone. Firstly, I would like to thank my respected seniors for giving me this opportunity to attend this prestigious lecture. I would like to present on management options in strabismus surgery under the guidance of my mentor, Dr. Subhash Dadia. So as we know that reoperations are expected in 5 to 10% of strabismus surgeries, most commonly in the complicated cases like SOP or DRS, and with persistence, satisfactory results can be achieved in 80 to 90% of the cases. Importance of the Cooper's dictum has already been explained in detail by respected sir. Patient should be treated as a new case on the basis of current findings, and if there is no limitation of the motility, surgery should be performed on unoperated muscles, and if there is motility restriction, surgery should be performed on previously operated muscles. So I would like to show 3 case scenarios in short with different management approaches. This is the first case. The 19-year-old male patient, he was referred to us from outside with history of bilateral 6 millimeter MR recession for infantile esotropia in 2009, following which he developed residual esotropia. Then he underwent bilateral 8 mm LR resection. He then developed consecutive exotropia. He came to us with consecutive exotropia. On examination, he had 30-degree exotropia in the primary gaze with extraocular movements full and free, with 50 prism diopters of deviation for near and 60 prism diopters for distance. So we did the ASOCT of the patient since all the 4 muscles were operated. In the right eye, MR was found at 11.5 millimeters on ASOCT, and the LR was found at roughly at 6.5 to 7 millimeters. So he was planned for the right eye exploration. In the right eye, MR advancement was done, and 8 mm LR recession of the resected muscle was done. So this is a surgical video. After the application of the traction sutures, limbal based conjunctival incision was given since the area was scarred for good exposure of the surgical field. This is the right eye, and the LR is being operated. So after cleaning all the scar tissue, the LR was hooked and secured with double-ended 6-0 vicryl sutures. After achieving hemostasis, it was disinserted, and further 8 mm recession of this already resected LR was done. Now proceeding to the other side, again giving limbal incision. Previously, MR was recessed, and on ASOCT it was found at 11 mm. In TRAU also it was found at 11 mm. It was secured with vicryl sutures, double-ended. And after marking 5 mm from, firstly it was secured. After marking 5 mm from the limbus, MR advancement was done. So this was the post-operative day 1 photograph of the patient showing orthotropia. In the next case, 26-year-old male patient presented to us with outward deviation of either eye since 2 years. There was history of the right eye 6 mm MR resection and the 9 mm LR resection in 2022 for exodeviation, and he presented to us with residual exotropia. So there was 10 degree of exotropia in primary gaze with 24 prism diopters of deviation. So here the right eye was the previously operated eye, and since the maximum amount of recession and resection has already been done in the right eye, he was planned for the nave eye, and extraocular muscles movements were also full and free. So in the left eye, 9 mm LR recession was done, and on post-operative day 1, he was orthotropic. In third case, 24-year-old male patient, he presented to us with inward deviation of the right eye. There was history of bilateral MR recession 6 mm in 2007, and in 2008, left eye 6.5 mm LR resection was done. The deviation was very small, around only 10 prism diopters, so we decided not to intervene surgically, and he was prescribed prisms, 5 prism diopters, base out was prescribed to him. So skipping these slides, as all these has already been discussed.
Do you want to wrap up, please?
Yes, ma'am. So I would like to conclude by saying that resurgeries are an important part of strabismus management. For mild or over and under corrections, non-surgical management like spectacle prescriptions, prisms, and orthoptics work well. However, for the larger deviation, resurgery is considered. So it is essential for us to maintain a realistic expectations and individualize the treatment plans for optimizing the results for resurgeries. Thank you so much.
Thank you so much, Vaishali. I think it is important for us to explain to the patient about the realistic expectations.
Yes.
Any comments? Do you want to
Uh,
unshare so that the next presenter can put up his slides?
I just wanted to say one thing. When you are recessing a resected muscle, then it acts like a pardon. So one has to keep that in mind. And when you are advancing recessed muscle, this is a bit tight muscle. So the results may be more than what it to be recessing the muscle otherwise. So I think these things have to be kept in mind.
Okay,
With
sir. Yes, sir.
yeah.
So do you want to unshare, Vaishali, so the next presenter can put up his slides?
Yes, ma'am. I'm trying to unshare.
Just go to stop share and you should be able to.
I think there's some, yes, ma'am, I found it.
Okay, great. So we'll have the next presenter. Meanwhile, and then after the next presenter, we'll take some more question answers with Dr. Kushner.
Dr. Manju, thank you.
Thank you, Dr. Dadia.
Yeah, I am leaving, sorry, in between because we have to go.
No
For
worries,
the.
carry on. Sure,
Okay.
thanks. Yeah, so Ashish, please go ahead.
Yes, ma'am.
Dr. Ashish, please unmute yourself and start your camera, please.
Yes, sir. Yes, sir. Am I audible to you, sir? Am I audible to everyone?
Yes, yes. Carry on.
Good evening, everyone. I'm Dr. Ashish, and my mentor is Dr. Saleen Kaur. Today, we would like to describe the utility of imaging in reoperations. My first case is I'm not able to move this. Excuse me.
Maybe stop sharing and start the sharing.
Yes, sir. Am I audible to everyone?
Yeah, just check if your slide is moving.
Yes, sir. Yes, sir. It's fine now.
Go ahead, please.
Thank you. Thank you. Good evening, everyone. I'm Dr. Ashish, and my mentor is Dr. Saleen Kaur. We intend to describe the utility of imaging in reoperations with the help of two cases. My first case is a 27-year-old male with complaints of left-eye downward deviation since birth, drooping of left upper lid since birth. He also
I'm
had history
sorry,
of
we can't see your slides. I think it's not moving. Are you on
Right.
slideshow?
Yes, ma'am. Yes, ma'am.
No, okay. Move to
You're
the
not
next.
you're not on slideshow, I think. I mean, I can see the background slides. So do you want to go on slideshow mode?
Yes, ma'am. 1 minute.
Just press slideshow.
Is it fine
Ashish,
right now?
Yes,
yeah,
yes.
now it's okay.
Go
Yes, sir.
Go
ahead.
ahead.
Go ahead.
My patient is a 27-year-old male presented to eye center with complaints of downward deviation of left eye along with drooping of left upper lid since birth. There was no history of decreased vision, diplopia, or trauma. He also had history of squint surgery 11 years back, which he lost all records.
Dr. Ashish, just click on the screen. You should be able to move the slides.
Yes, sir. Yes. There was a scar on the inferior conjunctiva, there was a scar on the inferior conjunctiva in left eye. We could see that the scarring is around 6 mm from the limbus and around 15 to 20 degrees of hypertropia. 1 minute, sir. I guess screen sharing has been stopped. Am I audible to you?
You're audible. You just don't press on the screen much. Just relax and advance as you speak. Right.
No, that's fine. There was a scar on the inferior conjunctiva, approximately 6 mm from the limbus. There was a hypertropia in left eye with large secondary hypertropia and some amount of pseudotosis. The patient has, on inspection, the patient has no lag of thalmus. There was fair wells in left eye with Marcus gun jaw winking phenomena present. There was hypotropia on left eye measuring 25 diopters with an exotropia of 10, increasing to 30 diopters in all up gauges. We can see limitation of movements in left eye on elevation, dextro elevation. However, there is no limitation of movements of right eye. There was left eye suppression on sensory examination with only gross diopters present. Forced duction test is free for inferior rectus and forced generation test is normal for superior rectus. So it looked like an operated case of monocular elevation deficit. But since we didn't have records, we investigated with an ASOCT. In ASOCT, a normal inferior rectus can be seen as an hyperreflective shadow and can be measured. Here in our patient, we could see that the inferior rectus was recessed as the inferior rectus was not at its normal location and there was conjunctival scarring overlying it. We could trace the whole width of medial rectus and lateral rectus and note that they were not operated. So we came to a diagnosis of monocular elevation deficit type 1 or 3 with mild ptosis, fair LPS action, and with Marcus gun jaw winking. As we suspected the inferior rectus to be recessed, we planned inferior rectus exploration and NAPS. On inferior rectus exploration, we found that the inferior rectus was recessed and was seen around 6 mm from the insertion, confirming our OCT findings. Lateral rectus and medial rectus were then transposed along the superior rectus. These are the postoperative day 7 pictures of a patient where we can see that there is no hypertropia in primary gaze. My second case is a 35-year-old male patient with history of trauma, fall at home, and old records show inferior rectus muscle tear repair. There was around 16 prism diopters of hypertropia at primary gaze with 8 prism diopters and 32 prism diopters at up gaze and down gaze respectively. In this video, we can see that there is limitation of depression in left eye, and on depression, we could see that there is inferior sulcus fullness. On ASOCT, the right eye inferior rectus can be easily viewed, but the left eye inferior rectus appears to be somewhat distorted. On careful examination, we could see that the inferior rectus fibers of the left eye were injured. On MRI, the posterior belly of inferior rectus seems to be intact. So we got a dynamic MRI done, in which the patient was asked to look up and down. We could see the contracting belly of inferior rectus. So on table, we could find there is a flap tear of the inferior rectus. So we were able to correct it. These are the preoperative and postoperative pictures of a patient, where we could see that there is no hypertropia at primary position. At postoperative 2 months, the patient has gained some depression as well. So there are multiple difficulties in the operations. Most often, the patients rarely know their histories. Clinical examination, history, and photographs are what we usually rely upon. And mostly the muscle is not where we expect it to be. Anterior segment OCT in reoperations were proven efficacious by many studies. Some of the studies from our institute, we have also published many studies from our institute, some of which from a mentor compared ASOCT with wide field ultrasound biomicroscopy, where it has been proven that ASOCT is more accurate and more comfortable for the patients. MRI is also useful in reoperations, especially in setting of trauma. Although it's useful, limitations are also present like cost constraints, availability, time, and expertise. And there is also slow learning curve. Gold standard is always clinical examination and on-table clinical findings. I thank my mentor, Dr. Saulin Kaur, for giving me the case, and Dr. Jaspreet Sukhija for head of pediatric ophthalmology at AAC. I also thank Aios for allowing me to present at this honorable
Thank you
occasion.
so much.
Thank you.
I think we could just take some comments from Dr. Kushner as to how much of imaging modalities would you use in resurgeries, and how often would you use those?
In the meantime, you can stop sharing, Dr.
Dr. Ashish, if you stop sharing, and we have the next presenter to share, Dr. Muskan.
The Kushner, you're muted. I'm sorry.
Is Dr. Kushna able to unmute or?
I think there is a problem with the transmission. It happens. It happened earlier also once.
Okay, sorry. I forgot that I had muted myself during the presentation. I think that these are all were interesting cases, and I'd say that our use of imaging has really helped our management in these. The use of OCT is, of course, newer, and I personally, just given the age at which I stopped doing surgery, don't have as much firsthand experience with it, but I think it's really been a remarkable addition to our armamentarium. I like the slide in this last talk that said there's a steep learning curve with MRI. And just a comment I'll make about that, I always, when I'm consulted about a patient by email or whatever, and someone says that, they got an MRI and it was normal, I always say, did you look at it yourself? Because in my experience, at least in the United States, most neuro-ophthalmologists, most radiologists have no formal training in looking at the extraocular muscles. And by default, it's usually done by neuro-ophthalmologists because the muscles show up on scans of the brain, the head, and they're the ones most used to looking at them. But I remember one case that I always try to avoid testifying in litigation cases, but there was a particular reason that I did in this case, and it was someone who had sinus surgery, and they got into the orbit with the machine and completely chewed up the medial rectus. Medial rectus was completely gone, not attached anywhere anteriorly to the globe. And a neuroradiologist read it as extraocular muscles are normal. So I'm testifying before a jury, and I'm trying to explain to them. I showed a picture. This is what a normal MRI looks like, and here's the muscles, and this is what this patient's look like. Look, there's no medial rectus muscle. And the attorney said, and how much formal training have you had in neuroradiology reading, Dr. Kushner? This was a board certified neuroradiologist who read it. And it just, what I had to say just went right out the window. They just, it was ridiculous. But my point is, now I worked with a neuroradiologist, many others do, who had a particular interest in eye muscles. So I always had him read the film. We'd read them together. And even then, he was very good, but he retired a handful of years ago. I don't think I ever really got him to understand the difference between a mechanical restriction and a paresis. He'd look at the scan and say, the eye's restricted to adduction or whatever. And I keep saying, but a restriction carries a specific connotation, and what he means is limited. So I think the important take-home point is you've got to be able to read these yourself, or develop a relationship with a radiologist who does.
Yeah, that's a very important, useful pearl. Yes.
Yeah. That's my comment.
That's great. Thank you so much. Thank you. So let's move on to the next case, and then we'll take some more discussion. So Dr. Muskan, are you able to share your slides?
Yes, ma'am. I'll start sharing.
Thank you. So if anyone else needs to sort of join in somewhere else, just let us know. We can change the order slightly. But Muskan, then Divya is what I have with me. Yeah, go ahead, please.
Okay, so my case is on monocular elevation deficiency. I am Dr. Muskan Mangal. I'm a DNB resident, and my mentor is Dr. Zai Kelkar. My case is about two children. One is a 4-year-old female child, which was brought to our department by her parents with a complaint of drooping of left upper eyelid since birth. And the other was a 3-year-old boy who presented with the similar complaints in his right eye since birth. On examination, both the children had no relevant excuse me. No relevant past medical or ocular surgical history. No history of any known allergy. Family history was negative. General examination was normal, and systemic examination was also normal with no signs of any neurological deficits. On ocular examination, the lid showed severe ptosis. After elevating the ptotic lid, the eyeball was deviated downwards. Extraocular movement showed restriction in the left eye with the girl child and in the right eye with the boy child. That is, all the three movements in the elevation were affected. The levo elevation, the dextro elevation, and the up gaze. Rest of the ocular movements were within normal limits. There was also a abnormal chin up head position observed in both of the childs. Uh, on doing cover uncover test, we revealed that the left eye in the girl child showed hypotropia, and in the right eye of the boy showed hypotropia. Uh, to rule out diplopia, we did Wirth's 4-dot test, and Bell's phenomena was also normal in both of the child. The jaw winking phenomena was present in the boy but was absent in the girl child. There was a unilateral limitation of elevation in all the vertical positions of the eye. So for management, as we all know, the monocular elevation, one second, I'll play a video. So first, for any strabismus surgery, we should always check with the force duction test. So we did that similarly with this also.
I think you need to be in slideshow mode. Oh, okay.
Yes, it's fine. It's not playing in the slideshow. I don't know why. So this was the force duction test that we did during the like before starting the surgery to see if there is any inferior rectus like restriction or anything, and to rule that out. And as the force duction test was negative, we proceeded with the NAP surgery. So this is the surgery video. I'll just play it for all of you. So as you can see, we did the post-duction test, and then we resected the horizontal recti first. So the medial recti and the lateral recti was resected, and they were transposed over to the insertion of superior rectus muscle. So as you can see, both the muscles are being transposed to the superior rectus muscle as the NAP surgery. So this is the final, and in the recovery after the NAP surgery. So this is the girl child on the right hand side, on the left hand side, that we can see that she is now orthotropic in the left eye, and the boy in the boy the ptosis was not corrected, but the elevation, if you can see in all the movements, he is able to move his eye. So here also the jaw winking phenomena can also be also be seen when the father says the child to open his mouth. Sorry, the father says to open the mouth. The child is also having some movement of the right upper lid. So the elevation is gotten better in the boy child. Thank you.
Thank you so much. So
Dr.
that
Muskan, I think just a comment. When you said that Bell's was normal, it would generally imply that the IR inferior rectus FDT would be free, because you had clinically already said that Bell's was normal. So it's good that you did the FDT again, but clinically it implied that it was free.
Okay. Okay.
I was going to make the same comment.
had a quick question. Savlin, do you want to go ahead
Yeah.
with your question?
I want-
to Doctor. Yeah.
Yeah, I wanted to ask Dr. Kushner because I've been reading his work and how he commented on Michael Struck's contralateral SR recession that he prefers over NAP in a case whose FDT is free. So you still like to do a contralateral SR rather than a NAP?
That's so
Thank you.
you both preempted my two. Those were the two comments I was going to make. One of my excuse me, one of my colleagues, Michael Struck, has been approaching monocular elevation deficiency by doing a small recession of the inferior rectus in the affected eye, depending on how much, if there was tightness, depending how tight, and then a very large recession of the contralateral superior rectus to match the adduction deficit. And I think his results are good in the appropriately selected patients. If there's a really marked limitation of elevation in the affected eye, doing yoke surgery is not going to be that effective. But this patient, at least the first one I saw, I thought the elevation, I mean, there was still a big deviation, but it didn't just stop at the midline. There was some degree of elevation, and I think that that procedure, doing the inferior rectus and the contralateral superior rectus, also would have been effective. But I think the NAP procedure is also very time proven, and I think you got a good result. What I've never been, excuse me, what I've never been happy with cosmetic, I mean, there's nothing better you can do, is what the jaw winking. That a unilateral, disinserting the levator and a unilateral sling doesn't work that well for day in and day out. They don't walk around raising the lid if they can see with their dominant eye without doing that. And most patients are not that accepting of what to me would be a very radical procedure, is denervating, doing it bilaterally. So it's just something that you can improve upon, but never get it as good. And actually, we can get the motility better than the lid, I think.
Yeah, exactly. Thank you so
I think
much.
if there is pseudotosis, I'm sorry. I'm saying there is
Go ahead.
pseudotosis along with MED, then resisting the other superior rectus does help, because the pseudotosis part is going to get better. So that's, I think, one indication, and one has to do a large recession. And I've seen with time this effect does wane to some extent. And the other thing is, in MED, you may get primary position orthophoria. The elevation part may still be not totally complete. Some elevation deficit may still remain. So the aim should be to have orthopropia in primary position. Some elevation deficit may still remain. I think that one has to keep in mind.
Okay. Yeah.
Thank you so much. So I'd request Divya Motwani if you want to share your slides next.
Yes, Dr.
And after her, Akhila, be ready. So Zai, that was a great case and great management. Can you go to slideshow, please, Divya?
Yes, my
Yeah,
slide.
thanks, Manju, and thank you very much for the discussion. Definitely useful.
Thanks. Go ahead, Divya.
First of all, thank you, Dr. Manju and Aios, for letting me be a part of such a wonderful session. So let me take you through a case when the going gets tough. I have no financial disclosures. A 59-year-old male from Hyderabad presented to us with the chief complaints of vertical diplopia. He also had no history of trauma, fever, neurological symptoms, any diurnal variation, weakness, or any other generalized symptoms. He was a known case of hypertension and hypothyroidism. There was a history of strabismus surgery that he had undergone elsewhere. So let me take you through this patient. On presentation to us, his best corrected visual acuity in both the eyes was 20/20. There was mild lid retraction and a lid lag in down gaze in the left eye, along with both eye mild conjunctival congestion. There was no caruncular congestion that was seen in this patient. Hurtle's exophthalmometry showed a difference of 2 mm in both the eyes. Going to the past history, it was seen that previously the patient was documented to have a left hypotropia of 25 prism diopters elsewhere and was a known case of inactive thyroid eye disease. He had undergone a Botox injection of 3.5 international units in the left eye in the IR muscle. After 2 months, the patient had presented with a left hypotropia of 40 prism diopters, and the patient had again undergone a left eye IR recession or mini tenectomy, but the details were not available. Further, on presenting to us, he had a 40 prism diopters of left hypotropia, and as we can see in the 9 gaze pictures, his elevation was limited in all the gazes of -4. So we had planned to go ahead with an FDT, but before that, looking at the MRI, we had seen that in the left eye there was a very bulky IR that was present. Both the eyes LRs were also seen to be bulky, which was seen on the coronal as well as the axial section. After planning for an FDT, a left eye IR exploration followed by a left eye IR re-recession with a right eye SR recession under general anesthesia was planned. This is a video of the same. As we can see that the IR muscle was very tight, and we had further went with a conjunctival fornical incision, and there was a lot of scar tissue that was present which was dissected, and the IR was found to be at 6.5 mm itself from the limbus. So further, after tagging the IR muscle, we had disinserted it with the scar tissue. The muscle was placed 5.5 mm from the original insertion. So going to the timeline, the patient had first presented elsewhere with the 25 prism diopters of left hypotropia for which Botox injection was given. Further, 2 months later, the patient had underwent a IR recession or mini tenotomy. And after 10 months, when he presented to us with the 40 prism diopters of left hypotropia, we had planned for a left eye IR re-recession and an SR recession in the other eye. On 3 months follow-up, our patient was orthotropic. So as we can see, his extraocular movements had also become better, and he had no diplopia in primary gaze either. This is the photo of the patient when he presented to us and in the post-op days. So my questions to the panel would be, what is your experience in re-surgeries following botulinum toxin, and how long after the first surgery would you go ahead for the second surgery if required? Thank you.
Thank you, Divya. So this case was a bit challenging because when he actually presented to our hospital, he had already undergone a Botox injection first, and then as the record said, a mini inferior rectus recession. But the actually at the time of surgery, it was quite difficult. I don't know, with the Botox doing a re-recession, the conjunctiva was just so hugely scarred. So I don't know if that is always the case with Botox, or it was just this particular patient. And also with regards to the re-recession, because when we actually tried to locate the muscle, it wasn't really much recessed. So I'd like Dr. Kushner, Dr. Sharma, and all the panelists to just, if you can enlighten us. We start with Dr. Kushner, please.
Yeah, I do not find any difference in doing surgery after Botox injection. I'm not aware of that really being a problem. The muscles seem normal. There shouldn't be excessive scarring. I mean, obviously, you want to wait till after the effect of the Botox is worn off, so you don't want to do it during the couple months that the Botox would be active. But other than that, I don't expect any differences.
Sure.
How long after the first surgery, I think it depends on what you're dealing with. In general, if I want to be sure that things aren't evolving, aren't changing. You want to wait for stability. With a thyroid patient, I always like to have 6 months of stability before I would do anything. If I saw the patient after, I think I'm going to digress for a minute. A mini tenotomy would be a totally ineffective procedure for a deviation this big. I understand we don't know that it was a mini tenotomy, but you found the muscle not in a markedly recessed position. So whatever they did was probably inadequate. I think I'd be influenced a little bit on if forced suctions are still markedly positive, which they would be in this case, I would go back earlier. If it's just an undercorrection, but forced suctions are reasonably improved, I might wait a little longer. I tend to wait long. I'm thinking, I think I tend to wait longer in thyroid than I would, let's say, if a patient just had a restrictive hypo, let's say after an orbital floor fracture or something like that, just because there is this dynamic aspect to it that if the underlying immunologic condition changes, the motility may change. But I think if I saw a patient and would I go back 6-8 weeks later? I think I'd wait longer in thyroid.
Right.
But I have a set, I can't, it's too individual. I can't say X number of weeks or months.
Thank you.
Anybody do anything differently?
I think in thyroid eye disease, the IR is tight and the Botox may not work that well because it's a contractured muscle. It is not something overaction, it is a contracture. So Botox, to my mind, will not work as well. And FDT definitely must have been positive. So a re-recession of the IR probably would be more appropriate. Maybe we can transpose it medially to avoid A pattern. I think that should be my point of view.
I think Botox should be considered as a relative contraindication if there is in thyroid conditions.
That's what I'm saying.
I have, when Botox first came out, Alan Scott described thyroid as one of the ideal indications for it early in the evolution of disease. And I was uniformly disappointed with the results. I stopped doing it after the first, I don't know, it was a long time ago, 1978, 1980. The first handful of patients I did, I just never got any decent effect from it.
Right. Great. Thank you so much.
Thank you.
So let's move on to the next presenter. Are you ready, Akila?
Yes, ma'am. I'll just share my screen.
Thank you. Can you go to slideshow mode, please, and start? Thanks.
Yeah. Is it on a slideshow mode?
Yeah.
Okay, thanks. Good evening, everyone. Before I start, I would like to thank Aios and Dr. Satya ma'am for giving me this opportunity. My presentation today is about a case of overcorrected intermittent exotropia. So the incidence of consecutive esotropia in IXT is reported to vary between 0 to 11% based on the post-operative follow-up period. In children, the desirable initial post-operative ESO deviation is 5 to 15 prism diopters to account for the exodrift that happens. But if this ESO deviation is beyond 18 to 20 prism diopters, there is a risk of consecutive esotropia. And the known risk factors are amblyopia, high myopia, divergence excess, lateral incompetence, and aggressive or asymmetrical surgical dosage. So we had a 7-year-old girl who presented with intermittent outward deviation of left eye since the age of 1 year. So she had no refractive error even on cyclorefraction. She had a good sensory fusional potential. On cover test, she had intermittent exotropia with a dominant right eye. On alternate prism cover test, the deviation was 25 prism diopters for distance and 30 for near, with a V pattern measuring 20 in down gaze and 40 in up gaze. This patient was on patching therapy in the past, but because she had worsening control, we had advised surgical correction. So preoperatively, we did the 1-hour monocular occlusion testing, and post-patch test, the deviation was 30 prism diopters for distance and at 6 meters and 35 prism diopters for near with a V pattern as before. And she had inferior oblique overactions in both the eyes, but it was quite asymmetric, more in the left eye. And this was in fact matching with the torsional examination, torsion on fundus examination. So it was a clear case of basic intermittent exotropia. So we proceeded with surgery. Intraoperatively, the post-duction test was negative. So we underwent, the child underwent inferior oblique Parkes recession in the right eye and anterior transpositioning in the left eye, along with an RNR procedure. That is a lateral rectus resection of 7 millimeter and a medial rectus resection of 5 millimeter. But post-operatively, on POD1, she had an ESO deviation of 14 prisms for distance and 16 for near. But to our surprise, there was a -2 limitation of abduction. And so though we had a possibility of, though we had LR slip, we were thinking of LR slip, still we prefer to wait for a week, thinking that it could be also due to a medial rectus spasm. So when the patient turned back at 2 weeks, she had a small left face turn and the abduction limitation still persisted. But the ESO deviation actually reduced to 8 PD at near. But this time, we thought we have to explore the LR muscle. So though we explained this to the parents, they were initially a little hesitant and they turned up only after 1 month. And this time the child started appreciating the diplopia in left gaze. So the abduction limitation also persisted. And this time we were also able to measure the lateral incompetence. So the ESO deviation was about 30 prism diopters on levo version. So we took her for resurgery. Actually, this was the 9-gaze picture before we took her for the second surgery. So as we can see, the abduction is -3 in the left eye. So we also did an OCT before surgery, but this is our initial experience with OCT. We only could infer that the lateral rectus was not lost. During resurgery, the on post-duction test, to our surprise, actually the medial rectus was tight. So given a second chance, we also explored the LR and we found that the LR muscle was actually in the intended position and there was no slip of lateral rectus. So since the FDT was tight, we went ahead and did a MR recession of 2 millimeters since it was very tight and left it on adjustable this time. So this is the POD1 picture. The child was orthophoric now for distance and near in primary gaze. But the abduction limitation, though it improved, it did not improve to full extent. But child was happy because there was no diplopia or face turn. And we have been following this child for the past 1 year. So still she remains ortho for distance and near in primary gaze. But the abduction is still at -1. So whenever something wrong happens, we go back and see what could be the possibilities. There was no measurement error in this case. Neither we missed a pattern or incompetence, nor the dosage was wrong, nor it was an aggressive amount of surgery. And the LR was also not slipped. So I would like to request expert opinion on whether it could be due to a tight overacting medial rectus, which is overpowering a surgically weakened lateral rectus. And is it common for such a normal dosage to happen? And if at all we have to recess tight muscle, what could be the surgical dosage, the reduction in the surgical dosage? And as the abduction limitation still persisted, so could there be a reverse leash restriction laterally or should the LR also be advanced in this case? Thank you.
Can I ask one question, if I may? You probably said this, but how long did you wait between the first operation and the second? I missed it.
So 2 months.
Months. Well, should I go ahead and comment?
Yes, please.
Please carry on.
So a few things. I have a personal bias for symmetric surgery in intermittent exotropia. And I know a lot of people have a equally strong bias for doing R&Rs. But one of the main reasons for my bias is that a recess resect is an incomitant procedure. And you predictably, if you're going to correct a significant deviation in primary, at least initially are going to have a limitation of abduction. And in my experience, patients don't like that. They're diplopic and side gaze. And if you don't really get some incomitance, you probably haven't done enough surgery. I don't think anything necessarily went wrong. I think that, what I tell my patients is that the surgery is based on averages. I use the analogy, it's not exactly correct, but that if you think of muscles like rubber bands, if you shorten them, they don't pull as hard. If you stretch them, they pull harder. And it's based on averages. We know the average eye, you move a muscle so many millimeters, the eye changes position so many degrees. And averages are that. Some eyes move more and some move less, and that gives you an average. I don't think you had enough of an adverse outcome to say something really went wrong. This may just be the variability in surgery. If I have now, I know that the books say, you want this initial overcorrection was within the range that they say is ideal. My own experience is, and I'm sorry, how old was this patient again?
7 years, sir.
7, yeah. My own experience is adults don't straighten as easily and quickly as children, but this is a child. If I have this degree of limitation of abduction after an R&R, I will intervene in one of two ways. Initially, I do what actually, I think this works. I don't know. I think of it as physical therapy. I will, a couple hours a day, have them patch the good eye and passively rotate. A muscle's a muscle, and just like you can stretch out your hamstring after or your calf after an Achilles tendon rupture, you can stretch out the muscle. The other thing, in my experience, one of the very few, I never use a lot of Botox, but one of the two indications that I think it's particularly helpful is to loosen a tight muscle in the immediate postoperative period. So if I were looking at the patient and I said, this is more of a limitation than I'm comfortable with, this is lasting too long, I put Botox in the medial. And that really works well and will often avoid another surgery. The other thing, and this is just my experience, so other people have different experience, I will almost never do a unilateral inferior oblique anterior transposition and either nothing in the other eye or just a standard recession, because I find it usually makes them very incomitant, particularly a hypo and upgaze. You got a very good outcome from the vertical. So my experience is not reflected in what you did, but that's something that I usually avoid against. And your last comment is reversely. I suppose I can never say it's not a reverse least restriction. I don't have any reason to think that. I mean, when you do an R&R, the other reason I'm biased towards symmetric surgery is I think a resection is a much more variable procedure. The amount of stretch that we have on the muscle even if we try to be uniform and all that, there's just more variability. There's a higher chance of getting a restriction with the same amount of resection that did just fine on a previous case. It doesn't happen. I mean, people do them all the time and they get good results. So I'm not saying it's a bad procedure, But there is that possible variability in how much tension was on the muscle when we measured back the number of millimeters. But I think you got a very good outcome, and certain percentage of patients need additional surgery. So those are my comments.
Thank you.
I think this was a child, so we need lesser doses in children. The same amount of surgery has more effect in children as compared to adults. So I think that we should keep in mind. Maybe that was one of the reasons. And as sir was saying rightly, that we should go for bilateral LR resection rather surgery or RNR. To my mind, I also do bilateral LR resections rather RNR, because you also have narrowing of the aperture in some of these cases, and patients get very cosmetically conscious that the two eyes. They're not looking symmetrical. So those issues are there. Dr. Pradeep will not agree with me, but that's my
In this case, I would rather again go bilateral for the simple reason that the inferior obliques were also being done. So from the same inferotemporal fornix incision, I would have done the inferior obliques on either side along with the lateral rectus. And that is what I would say, that symmetrical procedure should have been done. Also, the dosage, I think, is little more from my point of view. 30 prisms in a child doing 7 and 5, especially when we know R&Rs are more productive compared to bilateral recessions. So 7 and 5 is little larger for 30 prisms.
For a child, it is larger.
Yeah,
Definitely.
true. That again brings us to, with many different ways to skin a cat, sort of idiom, that there are many different ways to kind of get there.
But there may be a best way to skin the cat. All the ways may not be the same.
Let's move on to the next presenter. So Divya Kakulo, if you're ready, can you please share your screen?
Yes, ma'am. Yes.
I think I would like to make a request to Professor Kuchner. Sir, I am secretary of the SPOCI, and we had a very illuminating oration.
I'm sorry, I didn't get the
in 2021 at our Bhopal annual conference. So I'd like to request you for next year's annual conference in December that you give us an oration. In December only it is held, sir. So for next year, we would like to invite you. It was very illuminating and it was very well received by all the members. If you remember in 2021, sir, during Bhopal conference, we had your oration, sir, on intermittent exotropia.
So advanced booking.
Yes, sir.
Yes.
That will be really nice, sir.
Please, Divya, screen share.
Yes. Am I visible?
No, but you have not screen shared.
Can you share your screen?
Yes. Just. Is it visible now?
Not yet. Yeah. Now it's there. You can go for slideshow. Yeah.
Yes. First of all, I would like to thank Aios for this privilege. Very good evening to everyone. So my topic is residual or consecutive or operating surgeon Dr. Soumya R, Department of Pediatric Ophthalmology and Strabismus, Shankara Eye Hospital, Bangalore. A 30-year-old lady presented to us with history of squinting of her left eye since many years, history of use of glasses since childhood, and history of multiple squint surgeries done previously. Digging a little into her history, this is a picture of her prior to any surgical procedure. At the age of 13 years, that is around 2007, she underwent her first squint surgery. Whether one eye, that is the left eye, or both eyes were operated, details were not known. After that, she was apparently normal and the squint reappeared after some time. This was what she looked like, what squint she had after the first surgery, after which she underwent a second squint surgery in 2016 in the month of July. She was diagnosed as a left divergent squint and a left medial rectus resection and advancement was done. Following this, we don't have any picture of her. Then she says that the squint reappeared and she underwent the third squint surgery in the same year in the month of October. Here she was diagnosed as a left convergent squint and a 3 mm MR recession was done. So to sum it up, The first surgery was done for an esotropia in 2007, details of which we don't have. The second surgery was done for a consecutive XT in July 2016, and the third surgery was done in the same year in October. And this is our examination presently. The best corrected visual acuity in the right eye was 6/6, in the left eye was 6/24 N18. There was presence of conjunctival scarring nasally in the right eye and conjunctival scarring nasally and temporally in the left eye. The axial length measured 23.98 millimeters in the right eye and 22.60 millimeters in the left eye. Anterior segment and posterior segment examination was normal. On squint examination, Hirschberg showed a left esotropia measuring around 30 to 35 prism diopters with a -1 limitation of abduction in the left eye. Really sorry for the blurry picture. ASOCT was done and the medial rectus was found, but the exact measurements were not clear because of extensive scarring. So the challenges, So the challenges that we faced were, one, the left eye was amblyopic. 3 surgeries were already done. The patient was very concerned about the esotropia that she went into depression. There were palpebral fissure height changes and conjunctival scarring. The procedure we performed was a left eye subconjunctival adhesion release with a MR recession 6.5 millimeters on adjustable. This is a video of the surgery. The FTT was performed and found to be strongly positive. Paralimbal incisions were made and subconjunctival adhesions were released. The MR was isolated and hooked. Hydration of the tissues were done so that there is a little loosening and for better dissection. Part by part dissection was carried on to avoid cutting the muscle. Hooks were used to retract for better visualization. FDT was done again, was found to be negative. The original insertion was found to be around 2 millimeters. The muscle was found to be around 2 millimeters from the original insertion. The muscle was tagged and a re-recession was done 6.5 millimeters from the original insertion using a hemi-hangback for additional support with a slip knot nose. And the conjunctiva was closed. The LR was explored in the same sitting and was found to be attached on the lower border, the width being around 4 millimeter and being 2 millimeter behind the original insertion. Post-operatively, 1 week, we found a left esotropia measuring around 12 to 14 prism diopters. The patient was started on steroids. So the point of discussion that we would like to bring forward is that we are still waiting on the 1 month post-op, whether to see whether there would be a recurrence of adhesions, whether we could use an AMG or intraoperative steroids so as to avoid scarring, what is the role of Botox as an adjunct to weaken the MR intraoperatively. And since there is a presence of esotropia post-operatively, what should be the next approach? Could the other eye be taken up for surgery? What about fade-ins? Would it be a good surgical option in this case?
You want to go back to your questions slide so we can
Yes.
ask questions to the panelists? Thanks.
Yes.
Great. So maybe we can go through the panelists for possible answers. Should we start with Dr. Kushner, please?
Sure. First of all, this is a case where a significant part of the deviation was related to conjunctival scarring, because your force ductions improved, not normal necessarily, prior to disinserting the muscle. So you're dealing with a patient that, and this is perhaps why the patient ping-pong back and forth, ESO, EXO, either with surgical technique or the patient's intrinsic healing scars easily or a lot. I think Botox as an adjunct initially, shortly after surgery, would be very reasonable. Intraoperatively, I wouldn't have predicted that you'd need it. I mean, and as I said in my lecture, formulas don't count. You can't say ahead of time, you need to recess the muscle so many millimeters in this situation. It all depends on feel, how tight is the muscle, what are force duction, spring back testing, and so on. I would absolutely use something to avoid scarring. My personal approach has been to use steroids more than amniotic membrane, but amniotic membrane certainly a possibility. The other thing, and I was asked this earlier, this could be a case, and I would only make this judgment based if I were in surgery and could feel a case for recessing conjunctiva, both to improve the appearance of the scar over the medial area, but also to minimize any role of scarring from conjunctiva. And the last one, postoperatively, there's present esotropia. What should be the next approach? Could the other eye be taken up for surgery? Yes, dependent on there being no limitation of rotation or minimal limitation of rotation in this eye. If the ductions are pretty full and there's nothing, really significant in the way of limitation, the other eye is fine. If there's a limitation of rotation, not. That's what I would have to say about those questions.
Yes, sir. Post the conjunctival suturing back after the surgery, I did repeat the force duction test and it was completely free. And that's one of the reasons why I didn't go ahead and do the conjunctival recession. The initial idea was to do a conjunctival recession, considering that there was a lot of adhesions and the FDT did become negative post just the adhesion release, not even disinserting the muscle. So the idea was to do a conjunctival recession, but after the suturing of the conjunctiva, the FTT seemed okay, and I was able to bring it back to the original position, and the conjunctiva looked much better. So that's one of the reasons I didn't do it. Yes.
Makes sense.
Thank you. Any other comments or?
So I think limbal incision with conjunctival recession would have been better to my mind. And the way muscle was looking, it was looking quite botched up. I mean, probably first surgery was not good. It was all botched up. So probably more recession was maybe indicated. And that probably would have done the trick to my mind. Sorry, Dr. Pradeep, you were saying something.
Yeah, I was saying that in resurgeries, reoperations, when we have a lot of adhesions, something which I have found useful is using a swab stick dabbed with mitomycin C and applying it. And we have seen that the effect of this mitomycin C works for about 3 to 4 weeks. So the initial period, the adhesions will not come up. And I think this is something which can be used.
So
any specific concentration that we would use?
Yeah, the same as we use for glaucomas. No? The only difference is in glaucomas, you are having a partial thickness sclera. So you're more scared of its penetration. Here, it's a full thickness sclera you are applying. So it's relatively safer.
Thank you for mentioning that. It slipped my mind. I have used that in select patients, not very many, but I agree it can be very useful.
Will it prevent adhesion to the sclera, sir?
I think it does.
Yeah, sorry. Yeah, it does.
It does. So do you think some of it can be a little exaggerated and cause slipped muscle or...
So you see, the slipped muscle and all, we are having sutures for the muscle, which are going to be working for 4 to 5 weeks. The mitomycin C effect will wear off in about 3 weeks' time. That's what we saw in the study, that it doesn't last more than that.
Yeah.
Great. Thank you so much, everyone. So let's move on to, I think, lucky last, Tushar. Can
Yes,
you
ma'am. Is my slide visible, ma'am?
Yes, yes. Carry on. You can go for slideshow.
So, good evening, everyone. I'd like to thank Aios for giving me the opportunity to present on this forum. My mentor for this presentation is Dr. Swati Fulgile, and my topic is resurgery in inferior rectus palsy. So we had a 14-year-old female patient in whom the parents noticed an upward and outward deviation of the left eye since 1.5 years of age. The parents gave a history of a road traffic injury at 1.5 years of age. The patient had no diplopia and birth and family history was normal. Parents gave a history of a strabismus surgery in the past at 13 years of age. The record showed a pre-op horizontal deviation of 55 prism diopters exotropia, for which the patient underwent a left medial rectus resection of 6 mm and a lateral rectus recession of 7 mm that corrected the exotropia to some extent. On examination, the best corrected visual acuity in the right eye was 6.6, and the anterior and the posterior segment examinations were within normal limits. The left eye, the best corrected visual acuity was 1/60. There were scars visible in the temporal and the nasal conjunctiva. The pupil had a grade 2 RAPD, and fundus showed a disc pallor present. There was no abnormal head fracture, and fixation was central steady maintained in the right eye and central steady and not maintained in the left eye. Hirschberg test showed a 15-degree exotropia and a 15-degree left eye hypertropia with the extraocular movements showed a fairly full and free movements in the right gazes, with the limitation in the levo version in the left eye of -1 and a limitation in the levo depression in -3 in the left eye. On the 9-gaze measurement showed a primary gaze 30 prism diopters exotropia with a 25 prism diopters hypertropia. The exotropia was comitant in the right gaze but decreased in the left gaze to 14 prism diopters. So the hypertropia increased in the down gaze and decreased in the up gazes, with the maximum deviation coming into the levo depression gaze. CT orbits, we did a CT orbits which showed a bilateral symmetrical appearing inferior rectus muscles. So a diagnosis of a left eye post-traumatic inferior rectus palsy with residual exotropia with a left eye traumatic optic neuropathy was made. We did a forced duction test for depression for the patient, which was found to be free. So we are left with two options. We could tackle the vertical deviation in the left eye with the SR recession and correct the horizontal deviation remaining in the right eye. Although there were two operated horizontals, so there was a risk of anterior segment ischemia. The other option was to explore the already operated horizontal recti and go ahead with an inverse NAP procedure and tackle the horizontal deviation in the right eye in the future. We went ahead with the option 2, and the patient underwent an exploration of the lateral and the medial rectus with an inverse NAP procedure with a posterior fixation suture in the left eye. And the post-op 1 month picture showed an improvement in the hypertropia with a residual exotropia and also a marked improvement in the depression in the left eye. So this part has already been discussed earlier. I'd like to conclude by saying that we need to have individualistic, realistic expectations and have individualized patient planning for the patients. Thank you very much.
Great. Thank you so much for your case, and Swati, well done. Any comments?
Thank you, Dr. Manju. So I was just wondering what would have been the best approach in this case, because I was also thinking that if I don't manage to get, my horizontal muscles there, or I'm not managed to find them at their place, maybe doing an IO total anterior positioning would have corrected the hypertropia in left eye. But I'm not sure whether it would have given this kind of depression movement in that eye. So I would like to have expert opinion on this by Dr. Kushner and Dr. Pradeep Sharma. Sir?
So my first thought, especially with the history of the motor vehicle accident when young, was that there's a flap tear of the inferior rectus. And I think that's probably the most likely explanation, but maybe not. So I would have looked very carefully for that. But in the absence of finding that, I'm not saying you would have, I'm just saying that's a possibility. I think the inverse NAP procedure is also what I would have done. It's always tricky doing a NAP or an inverse NAP after there's already been a recess resect of the horizontal rectus muscles, because you don't know. It's always a guess where to put that recessed muscle. Do you move it down to the insertion of the inferior rectus as though it hadn't been recessed, or do you maintain its previously recessed position? And I don't have an answer for that. I just know that I ponder that whenever I'm doing those. Unfortunately, it's not that often, and try and make a reasonable judgment. What did you do? Did you, let's say the lateral was back, I forgot how many millimeters. Did you put it that far back from the inferior rectus insertion or at the inferior rectus insertion?
Yeah, that indeed was my concern also when I was exploring lateral rectus. So the idea was to get the maximum vertical effect, and I tried to get lateral rectus as anterior or as closer to inferior rectus insertion as possible. Because it was an already operated muscle, it was little tight, so I might not have been able to put it exactly at the insertion of inferior rectus, but it was fairly close to it.
Thank you.
Yeah, and so for the medial rectus as well.
I think as Professor Kushner has said, right thing would have been to look at the flap tear. That is, I think, in view of traumatic optic neuropathy and poor vision, that was the most likely possibility, and that aspect should have been looked into. And maybe torsion, evaluation of torsion would have also told you that if there is intorsion, that will probably go for inferior rectus flap tear or something. I think that should have been considered, I think,
We
as
looked into
surgical
it
option.
in CT scan, and we found that both inferior rectus were equally bulky, and we couldn't trace any kind of tear. Even the anterior portion of the inferior rectus on CT scan looked absolutely okay.
They may
So
not appear on the imaging, you have to explore and see what is happening. Imaging can be at times misleading in these situations. So I think it was best to explore and see what is there.
Yeah, so the intraoperative force reduction test would be the things which will guide us in handling such cases. And I have seen that sometimes you can do a modified inverse naps to to correct both the exo as well as the hypertropia. So you may use the resection of the medial rectus to correct the exotropia. The recession of the lateral rectus is only on the basis of the force reduction being tight, because you don't want to reduce the vector force of the lateral rectus. You don't want to over recess a muscle. You just want adequate enough for the FDT, and the medial rectus you can resect in order to improve the force of the downward movement. So that is what I do, modified inverse snaps in such case.
yes, sir, that's absolutely right, and that's what I learned from you. But in this case, it was an already resected medial rectus. So I'm not sure how much more it was already 6 mm resected. So I don't know how much more I could have resected it.
So in such cases, doing the inverse naps as you did may have worked
Or
for it.
single muscle, or balance it with surgery.
But the primary problem was probably likely at the IR. That should have, I think, should have been addressed.
Okay, maybe.
Let's move on to the last case so that we wrap up in time, and Santosh on hour gives us another opportunity for pediatric ophthalmologists because we finish on time. So the last case is the story of stretch scars. Dr. Shruti, please go ahead.
Good evening, everyone. I would like to thank Aios for giving me the opportunity to present a case in this grand round. I will be discussing the story of a stretch scar. So a 3-year-old child presented to us with complaints of squinting since early childhood. He had amblyopia in the left eye. There was moderate hyperopic refractive error on cycloplegia, a left convergent squint measuring 45 prism diopters for distance and near, and both eye inferior oblique overaction. So we prescribed the full cycloplegic error and part-time occlusion of the right eye, followed up closely. At 1 year, we found that the left eye vision has improved and there was minimal hyperopic refractive error on cycloplegia. The angle of deviation was 50 prism diopters, esotropia for distance and near, with inferior oblique overactions both eyes. The child was taken up for surgery, and a bimedial recession, 5 mm, and a left lateral rectus resection, 6 mm, was done with both eye myectomy. On follow-up, in the first post-op bed, there is a residual esotropia of 8 prism diopters for distance and 14 for near. At 1 month and 2 years, there was a residual esotropia for distance and near. However, over the next few years, the child moves from a small residual EP to a consecutive XT with a small amount of adduction limitation. So at 19 years, he opts for resurgery, and we see that the distance deviation was fairly equal in all gazes and tilts. and the near deviation was significantly more than the distance deviation with a small amount of adduction limitation. So we planned medial rectus advancement for this person, and intraoperative FDT was free. We opted for the limbal approach. There was some resistance during the hooking of the muscle, and we took all care to carefully identify the muscle. Intra-op, we find that in the right eye, there is fibrous tissue noted between the muscle and the sclera, as well as extending anteriorly up to 5.5 millimeters from the limbus. The original medial rectus insertion was about 10 to 10.5 millimeters from the limbus. In the left eye, the original medial rectus was at 10.5 millimeters from the limbus, and there was fibrous tissue between the sclera and the muscle. So this is the intra-op video where we can see that the second hook is showing the actual recessed muscle insertion, and the first hook is showing the overlying fibrous tissue. So this muscle is now carefully sutured, and we need to dissect the scar and the overlying tissue. Finally, we advanced the medial rectus in the right eye to 5 millimeters and the medial rectus in the left eye to 5.5 millimeters from the limbus, with meticulous dissection of the stretch scar and excision of the pseudotendon. FDT was free at the end of surgery. On follow-up, we see on first post-operative day, there is now a consecutive ET of 8 prism diopters for distance and near. However, over 2 weeks and 2 months, this slowly drifts out, and we now have a residual XT, more for near than for distance, with both eye conjunctival thickening. At 2 years, the angles remain to be fairly stable. Distance deviation is more than the near deviation is more than the distance deviation. So the considerations we undertook while planning surgery for this case was that it is a case of consecutive exotropia with near deviation more than the distance deviation, with a small amount of adduction limitation and no lateral concomitance. We opted for the limbal approach, though there was no conjunctival stretching or scarring. FDT was free intra-op. We expected the medial rectus advancement to give us an increased effect compared to the resection owing to the stiffness of the previously recessed medial rectus. Careful hooking to identify the original muscle and distinguish it from the scar tissue or the pseudotendon. The tenons and conjunctiva in this case were closed in separate layers. So we conclude that for preoperative clues in consecutive XTs, we should look for convergence insufficiencies or divergence excess to identify the muscle we would like to operate. Stretch scar-induced secondary strabismus should be suspected in cases with late over or undercorrection associated with limited duction of the operated muscle, and a meticulous dissection and identification of the muscle before we secure and disinsert it. Now, my questions for the panel is, should we aim for overcorrection in medial rectus advancement in consecutive XT where there is convergence insufficiency? And if so, then how much? If there is a stretch scar, what should be the surgical dosage of second surgery? And would you prefer a non-absorbable suture in resurgery? Thank you. And I would like to acknowledge Dr. Sujata and Dr. Anuradha's contribution to the case. These are my questions.
Well, I'll comment quickly on these. But first, it's a perfect example of, stretch scar and what I talked about in my lecture. I don't particularly aim for more of an overcorrection in this situation because I think of the convergence insufficiency pattern as being mechanical. We have a disadvantaged, a paretic, if you will, not neurologically paretic, an underacting medial rectus muscle because of the elongated scar. And if you correct for that underlying problem, the distance near difference should go away. If there's stretch scar, which is surgical dosage? I don't have a formula for this for the dosage. I'm totally basing, this is where experience just helps. I'm basing it on where I find the muscle, how elastic it is, how tight it is when I pull it forward, and how the eye is positioned, both as far as anatomic positioning, but response to forced suctions afterwards. And I've gone back and forth on the non-absorbable suture. Irene Ludwig, who described the stretch scar, really, and I think she's very smart, and she really feels strongly that if it's not a slip in the capsule, but it's a stretch scar, you have to use non-absorbable sutures. I have done many of these without using non-absorbable sutures, and I can't say that they didn't come out okay. So, although that's the teaching, I'm not sure I follow that completely consistently. And I don't think I can give you a good answer for when I do and when I don't. I'm probably inconsistent.
Thank you, sir.
Thank you so much. Dr. Pradeep Sharma, any of your comments?
I think that was wonderful wrap up by Professor Kushner. He already started with a wonderful talk on the reoperations, and we have a very good case to end up with. And it's been a really wonderful evening today, and a good day for Dr. Kushner. It's a day begins for him, and it's snowing in Wisconsin. It seems so. I mean, it was wonderful to have you here. I think it's time up for that. And we thank all the panelists. In addition to Dr. Kushner being there with us, we have all enjoyed your talk, sir. And
Thank you
for a wonderful moderation.
And I'd like to renew my request, sir, for next year, December 2025.
You can send it in writing to him.
Write me about it.
Advance.
Okay, I'll say goodbye. I'm just starting the day.
Thank you, sir.
Have a good day, sir. Thank you so much once
Thank
again.
you so much, sir.
Thank you for
Very nice
honoring us.
hearing you.
Thank you for chairing, Dr. Pradeep Sharma. It's always great to have you in all the
Thank you so much,
webinars.
Manju. Yeah, it's my pleasure too. And it's always something that we need to do for strabismus and pediatric ophthalmology in this part of the world.
Yes,
And
yes.
thank you so much.
Thanks for your
Thank you
support.
for moderating, Manju. You did great. We finished on
Yes.
time.
Yeah, very well done, Dr. Manju. Very nice. And Dr. Sablin, how are you? I hope everything fine. Good.
Thank you, sir. Good evening.
Push and finish on time. Thanks.
I'll say goodbye.
Thank